I know some of you, not all of you, but I'm Abby Delaney. I'm one of the reproductive endocrinologists here. So at my last talk, we talked a lot about diagnosing and workup for infertility. This talk, we're going to talk about sort of the mainstay of treatment, or like the first part of treatment before IVF. And then Amy and I, next time, we're going to talk a lot more about kind of male factor infertility and how that correlates, and kind of we'll tie it in kind of a nice little bow with IVF. But today is really going to be about ovulation induction, and so, you know, garden variety. When you come to see us and we diagnose you with really any form of infertility, these are some of the reasons. These are some of the things that we're going to do to try to kind of help do that. Okay, and this is outside of the realm of like surgery, meaning if you've got a big fibroid, I'm going to take your fibroid out, or if you've got a polyp, I'm going to take your polyp out. This is more like, this is what we do as infertility specialists, okay? So just as kind of back up, if you guys remember, one of the main things that we talked about last time is that you want to know whether somebody is ovulating or not. And that is, I will say, like almost a quarter of our patients. They have some sort of ovulatory dysfunction, meaning that every month they don't necessarily ovulate an egg, okay? And you don't necessarily need to do a ton of evaluation to do this if they're not infertile. But as we talked about last time, with infertility, I like to do the global workup, okay? But if someone comes to you and they're like, you know, we're trying to get pregnant, and, you know, I've heard that I need a 28 to 35 day cycle, and man, I mean, my periods are like every 40 to 70 days. I'm never regular. How can I tell, or how can I help myself get pregnant if my periods are irregular? Well, if your periods are that irregular, then you've sort of met the definition for an ovulation. And so the definition is women with irregular, unpredictable, or infrequent menses. And like I said, it doesn't really require a massive diagnosis, but if they're infertile, meaning they've had a year of unprotected intercourse if they're under the age 35, or if they're over 35 and it's 6 months of unprotected intercourse, then not only are they not ovulating, but they're infertile, so they need the full workup, okay? And then some people, you know, they're all on the blogs. Everybody's on the blogs, and they're reading about kind of, I've been doing this basal body temperature, which I'm not going to go into. Natural family planning is not my thing. But if you are so inclined, basically mid-cycle, there should be a slight elevation in temperature. It is very, very hard to detect. It is very flawed. People can't do it correctly, but if they are really into it and they're doing it correctly, they should see a bump in their temperature at the mid-cycle, demonstrating ovulation. How most people do it, and the most kind of, if you're really trying to figure out whether someone's ovulating or not, is you do this day 21 progesterone. And if the progesterone is less than 3, that implies an ovulation. But it has to be appropriately timed. So when I say day 21, that implies a 28-day cycle. But if your patient has 35-day cycles, then your day 21 progesterone is going to be day 28. So it's 7 days before the onset of menses. So when we talk about kind of, and the reason why it's important to kind of go over and sort of remind everybody about these diagnoses that we talked about last time is it sort of directs how we treat them. So when women don't ovulate correctly, there's really 3 groups and sort of a half group that I'll throw in there, and I'll talk about that at the end. But there's really 3 groups of reasons why women don't ovulate normally. The first group, so World Health Organization divided it into 3 groups to make it easy, is hypogonadotropic hypogonadism. So if you guys remember way back from the physiology days, when you were tired of studying, you're tired of reading, there was this pathway, if you remember, your hypothalamus connects to your pituitary, which connects to your ovary, okay? And everything starts with signals from your hypothalamus, from GnRH, then signaling to your pituitary to make LH and FSH, which then signal to your ovary to make estrogen and progesterone, okay? And if any of that pathway is messed up, then you don't ovulate correctly, okay? In this group, it's the very start that's sort of screwy, meaning that for some reason, your hypothalamus is not making that GnRH. It's not making the hormone that is necessary in order for your pituitary to secrete gonadotropins for your ovaries to work appropriately, okay? So how do you diagnose this? So you diagnose this on, you can do these, because usually these women, they're not oligo-ovulatory, meaning they're ovulating sometimes, not sometimes. Usually they don't ovulate at all. So usually they're just not having periods, okay? So you can test an FSH and an estradiol that day, okay? And usually estrogen is low and FSH is low, but sometimes it can be weird, like it can be normal. Examples of this and kind of clinically correlate with your patients are people that are hypothalamic, amenorrheic, secondary to exercise. So our bodies have a certain percentage of body fat as women that we need in order to regulate. And generally speaking, it's around 18%. And if you don't hit that 18% threshold, your periods can sort of shut off, okay? And so, college, athletes are constantly, taught to lose weight or taught to be a certain kind of weight percentage and fat percentage. And so this is a classic group of people that come to us and they're like, I'm running 20 miles a week and I'm not getting my period. And well, unfortunately, that's probably because your energy output is more than your energy input, and your brain, that's kind of nature's way of being like, you're working so hard, so you aren't working, like you're working so hard to get pregnant. Like you can't get pregnant when you're working this hard. So other things is like emotional. So this is, there can be things that are called idiopathic hypothalamic dysfunction. I've found this in like the question, am I too stressed? Patients will say, am I too stressed? Is that why I'm not getting pregnant? The shorter answer is no, but the long answer is perhaps, particularly if I can't find anything else. Now, generally this kind of stress is like, it's not just like, I had a bad day. Like this is like, my mom died, my dad died, my dog died, and, I'm just struggling to like get through the day. Or, I'm taking care of like a very, very sick person. Or, like significant life stressors to the point where that kind of shuts the brain off. Like, again, your body is too stressed. And that's Mother Nature's way of being like, we're done. Get healthy, get better, feel better, put on some weight, and then we'll get pregnant. Okay? Eating disorders, certainly it's sort of the same thing as like heavy exercise. And then Kallman syndrome, if you guys ever remember that, that's where people are born without the GnRH neurons. So they actually functionally cannot make gonadotropin-releasing hormone. And then there's just these like weird zebra people that have like, they just don't make gonadotropins, okay? For some reason or another, they require FSH, exogenous FSH, and we'll never know why. And usually those people I can never really like diagnose, because that gets down to like, I need to sequence your LH receptor, or I need to sequence your FSH receptor, and that's just like not clinically appropriate. So the second group is certainly our most common form of ovulatory disorders. So that's eugonadotropic, euestrogenic anovulation. So that's 75 to 85% of anovulatory women. These women will have normal FSH levels, they'll have normal LH levels, or elevated LH levels in PCOS, and they'll have normal estrogen levels. So if they do have a period and you do labs on day 3, everything's going to look normal. Okay, so there's going to be no highlight there. And the most common kind of culprit in this whole category is polycystic ovary syndrome. So if you remember kind of what we talked about last time, it is a clinical diagnosis. It is a diagnosis of exclusion. In order to meet the definition for PCOS, you need to have 2 out of the 3 things. You need to have polycystic ovaries, biochemical or clinical signs of androgen overaction, like male hormone, like male hair growth, balding, acne, things like that, and irregular menstrual cycles. So if you have 2 of those 3 things, you meet PCOS criteria. And so the bottom line with this is that it is important with these women to screen for type 2 diabetes because they're at risk because they have hyperinsulinism. And truly, for these women, if they're young enough and they're not trying to get pregnant, the best way for them to get their periods back without me having to do anything is lose some weight. And so that's that. The last group is hypergonadotropic anovulation. So that's where your FSH and your LH are very high and your E2, your estrogen levels, are very low. This is low, or this is uncommon. And the most common form of this is premature ovarian insufficiency or premature ovarian failure. You come into my office and you say, hey, my periods are really irregular. I check your FSH and it's 24. Unfortunately, you are in premature ovarian insufficiency, and unfortunately, there's very few things I can do treatment-wise to improve this diagnosis, short of donor using someone else's eggs, because your ovaries have failed. This was remember I said 3.5? So the half category is hyperprolactinemic anovulation. So 5 to 10% of women who don't ovulate will have an elevated prolactin level. Usually their FSH and their estrogen levels are normal. And if you find high prolactin level, generally if it's over 40. We have a very sensitive assay. I know I said that last time, but our assay is exquisitely sensitive, and there's lots of things that can elevate prolactin. So what I'm not suggesting is that everyone with a prolactin level of like 24 or 25, and the upper limit of normal in our assay is like 24, is that you go order MRI on all these people. That is a big waste of money. But what I am suggesting is if you are considering starting medication on somebody to lower their prolactin level, then I would suggest that you do an MRI of the brain, okay? And what you're looking for is a prolactinoma. And what we use to treat these are medications called dopamine agonists. So cabergoline is an example, or bromocriptine, okay? And so sometimes when we have patients and we diagnose hyperprolactinemia, we can just give a medication and within 3 months they're pregnant because all we've had to do is lower the levels of prolactin. So like I said last time, I'm sort of dividing this talk, and it sort of meets at the cross point between infertility or like irregular menses, right? So all women who come in and have irregular menstrual cycles deserve some preliminary evaluation. But if you are going to start treating them like they're infertile, if they're trying to get pregnant, then you need to do the full evaluation. You need to check the sperm, you need to check tubes, you need to be doing all of that. But if they're just worried about their periods and they're just like, my periods are weird, I don't know, like I get periods every 40 to 90 days, I can never tell when they're coming. The minimum thing that you need to do is a TSH and a prolactin level. And I would say if they're obese and if they have polycystic ovary symptoms, and if they are having periods every 6 months, you need to sample their endometrium regardless of age. Back when I was training, they used to say over age 35. And now the new recommendation is that there is no age cutoff because people get endometrial carcinoma even at a young age if they're not ovulating consistently. So we talked about most of that. So let's talk about treatment, because that's what this whole lecture is about. So the best initial treatment for obese and ovulatory women is weight loss. So what I tell these patients is, I'm not asking if you're 290 pounds. I am not saying that you need to be 150 pounds. That's not reasonable. And particularly depending on age, it's not reasonable if you're 38. I don't have time to lose that much weight before I'm going to have the ability to have kids. So what I do usually say is let's make a goal of 10% of your body weight. And I usually give them a BMI cutoff. I generally say, though, if your BMI is under 45, then we're okay for treatment. But over 45, it's dangerous for you when I'm using these medications to try to help you get pregnant because I can't monitor you effectively with ultrasound. And so we talk about kind of steps that we need to take, and I do a lot of follow-up with these patients. I set them up with dietitian. I do things, and then I usually reevaluate them and see how they're doing in 3 months if they're old. And old meaning 38, which is not old, whatever. But I usually do kind of follow up because these patients don't want to feel abandoned. Like, you can't be like, no, I'm not going to get you pregnant. There was that huge New York Times article. But it is in their best interests in order to conceive, but not only in order to conceive, but to be safe with any medications that we're using, to have at least a BMI under 45, because at least I can visually see an ultrasound. I can make sure I can see the follicles and everything like that. BMI of minus 27 is what our Spiroff, so our textbook, that's what that says, which I think is hilarious. That's very funny. But yeah, BMI of 27. Okay, right. Good luck. We live in Nebraska. So we're going to talk about the really the two main ovulation induction drugs, medications that are oral, that are pills, that I feel like any primary provider can utilize at their disposal in order to help women that don't ovulate appropriately. And we're going to then talk and go a little bit into more of like what we do with injectable meds. So 80% of women who present and they're not ovulating appropriately for really whatever reason, most likely PCOS, will respond to Clomid. Clomid is an estrogen antagonist and agonist, so it's a SERM. It's a selective estrogen receptor modulator. It's an estrogen agonist and at certain points in the body, and it's an antagonist elsewhere. The reason why it makes people ovulate is its antagonistic properties. So what Clomid does, Clomid actually goes up, binds to the receptors in the brain, and occupies the receptors for estrogen in the brain. And so your brain sort of responds by being like, hey, we don't have any estrogen, because Clomid's taking its space. And the ovary should respond by making eggs, which then produce estrogen, okay? And unlike some of the other medications that we use, Clomid is a medication that can build up in your system. So, and it's because this zuclomiphene, this mixture, it's a racemic mixture of this medication, it has a really long half-life. So what sometimes you will see is if you are not monitoring these patients appropriately and you're just handing out Clomid every month, they're just coming in for their Clomid, they develop big cysts on their ovaries. And they develop big cysts on their ovaries because there's Clomid left from the last month, or the month before, or the month before. And so I always encourage people never to just hand out a script for Clomid and not monitor, because you're not doing your patients a good favor. So, like I said, it works by basically binding the receptors in your brain. And it also binds receptors in your uterus, and it makes that environment hypoestrogenic. So the good thing is that it binds up in your brain and basically makes it look like your estrogen levels are low, so that your ovaries will produce an egg. But the bad thing about it is that it binds those receptors for estrogen in your uterus. That can thin your endometrial lining, and it can also thicken that cervical mucus. And so certainly, if somebody who is straight up PCOS and you've tried like 3 cycles of Clomid and timed intercourse, you really need to be taking a look hard and look closely at that endometrial lining, because if the endometrial lining is really thin, meaning like 5 or 6 millimeters, that Clomid is affecting any embryo's ability to implant, and Clomid is not a good drug for them, okay? But it is a safe drug. It's been studied forever. There's no direct effects on the ovary or the embryo. And it's really good for people in 2 categories. 1, PCOS women, and 2 are these kind of category of women that they come in and they say, I have regular periods, but I spot forever. And what I mean by that is, so my period will start on day 28, but I'll spot for, 3 or 4 days before that day 28 comes. And what that indicates is that they're lacking progesterone. And so you can supplement progesterone, but what's even better is if you make a better egg. And you make a better egg using Clomid or the gonadotropins, which we'll talk about in a little bit. Here is something we get asked a lot. Do you guys use oral medications? Because most of the time when patients are sent to us as the REI, they've already tried things. So they've tried things out in the community with their OBGYNs. They've tried Clomid. They've tried letrozole. They've tried these things. But I will tell you that I see a lot of patients that have not tried anything. So yes, I will use Clomid when Clomid is appropriate. But Clomid is not appropriate for everybody with infertility. And it's especially not appropriate for thin women who have unexplained infertility. Thin women already have difficulty making normal uterine linings, and so Clomid will antagonize the lining. Their lining will be thin, and it's not going to work, okay? And it's not great for unexplained infertility because the reason why they're unexplained is that they're unexplained. We can't find a reason. So just by making them ovulate, which is what they're doing already every month, isn't fixing the problem. And so I generally say we'll try one cycle of Clomid or letrozole, whichever I feel is more appropriate. And if it's not successful, then we need to move on to gonadotropins, which are kind of the big gun medications, which we'll talk about at the end. And the reason I say that is I'm not in the business of wasting your time. You want a baby, and I want to give it to you. So the bottom line is. It is standard of care to start with Clomid and IUI. That's what all the textbooks will say. But it's a very select patient that I won't go to kind of immediately. It's usually normal BMI women with great sperm, great lining when I monitor them, all of those things. Then yeah, Clomid we can do. But if the lining is off, if they're really thin, if they have any evidence of hypothalamic dysfunction, meaning that their brain is just not functioning and talking to their ovary, I'm not going to use Clomid. Okay, so how do you use Clomid? All right, so it's a pill. You take it once a day for 5 days. And studies don't really care whether you start on day 3, day 4, day 5. It's usually, I like days 3 through 7. That's just convention and what I have done. And there's no way for me to look at a patient and be you need 50 of Clomid, or you need 100 of Clomid, or you need 150 of Clomid. There's no way for me to sort of gauge. So generally, the standard of practice is you start at the lowest dose. So you start at 50 milligrams a day for those 5 days. I don't go beyond 150 milligrams. I have patients that have been sent to me that have gone up to 200, 250. It is not FDA regulated at that dose, and I do not feel like it is appropriate. And typically, what we do in our office is we have them come back for an ultrasound, usually on days, probably days 13 through 15, to try to see if we can see if they're developing a follicle. Conversely, you can have them use those LH kits or luteinizing hormone kits, the ovulation predictor kits, and if it's positive, you start having them do that usually cycle day 10, and then they find out if it's positive, then they have intercourse the next 3 days. Or, as we've already talked about, you can have them come in for a day 21 progesterone and see whether or not if it's greater than 3. And that basically looks and finds out, did you work? Did it work? Did it make you ovulate? Did you make an egg that month? So here is the Clomid check, and the reason why I do kind of baselines. So they take the medication, they come in generally on day 12 or 13, see if the medication worked, and then we choose to trigger them and do an IUI, or we say, okay, go have intercourse starting on X day. But we always have them come in for an ultrasound before we start the medication, because if they come in and there's big cysts, what we call residual cysts on their ovaries, the medicine's not going to work well, and it's dangerous. You don't want to have a cyst and then make another cyst, and then the ovary can kind of twist and things like that. It induces ovulation in 70 to 80%. People with amenorrhea, meaning they haven't had periods at all, are more likely to conceive than women who just have irregular menstrual cycles. overall cycle fecundability is around 15%. So that's what I tell my patients. If we're going to do an oral medication like Clomid or Letrozole and we're going to do IUI with it, I generally say the success rate is around 15%. And that I usually do this is the book answer is like 6 cycles, but I generally say that I do it for 3, and if 3 cycles are not unsuccessful, then we step up the ladder and move to something more aggressive. I do not use any oral medications on anyone over the age of 35 because the success rate is so low. That 15% assumes that you're of younger maternal age. The bottom line is, if you come to me and you're age 35 or greater, you're getting injectable meds because the data have shown that that is going to be what's necessary. What are some side effects of Clomid? People really do not like this medication. Usually people complain of hot flushes and mood swings. A very, very select few will have visual disturbances, and if they have those, then you sort of have to stop. Like, you can't use the Clomid. But for the most part, the biggest thing is kind of the mood swings. But again, remember and tell them that this is 5 days. You're just taking this for 5 days. What are the risks of multiples? So around 7 to 10%, triplets less, and then everything else is less than 1%. There's no evidence that like upping the dose increases success if your goal is just to make someone ovulate, right? So if someone ovulates on 50 milligrams, there's no reason for you to like reinvent the wheel and have them come back next month and do 100 milligrams. You're only going to increase side effects, and you're going to only kind of increase risk of multiples, which is unnecessary. So the bottom line is the goal with this is like just to make someone ovulate. That's why it's not great for women who have regular menstrual cycles, because they're ovulating every month. I have period, and it's normal. And so that's why it's really good for women that don't ovulate, particularly PCOS. No increased risk of ovarian or breast cancer, but prolonged treatment should be avoided, and that is because there has been increased risk of borderline ovarian tumors, so of low malignant potential. So those tumors are associated with lengthy treatment of infertility. So there's lots of like adjuvant combination treatments. So you can do Clomid and some glucocorticoids, which I'm not going to talk about. That's beyond the scope of this talk. You can do Clomid HCG, which certainly we will talk about. We can do Clomid and metformin. And then some people claim that, you can do this, if people have PCOS, you can do like 3 months of oral contraceptive pills before you do a Clomid cycle, and it helps them conceive. Generally, I feel like 3 months is a waste of time, but again, I'm skewed because I usually see women over age 35. So why would I use HCG? Why do we do this trigger shot? Okay, trigger shot is successful, or it works because Clomid. There's this thought that Clomid can make the egg and develop the egg, but some women are unsuccessful at luteinizing that egg and basically inducing ovulation. So some women can't ovulate. They can make the egg, but they can't ovulate. So we always do triggers with our cycles. And generally, in order to do a trigger, you have to do an ultrasound because you need to know how these follicles are growing. So if they come in for a baseline ultrasound, they take their medication cycle day 3 through 7. I have them come back, generally on cycle day like 13 through 15, and I take a look about how big their follicle that they're developing is. And if it's 18 to 20 millimeters, we're good. And then you can use a trigger shot. Some people, and I do generally push them out a little bit farther, like to 22, 23, and the reason why is because it seems to have more mature follicles and have higher success rates. This just is going into kind of, okay, now I've triggered, now I want to do an insemination. When do I do it? So usually, if they are using ovulation predictor kits, and they call and they say, hey, I had a surge, they come in, we take a look, we see if they're developing an egg, and if everything looks good, their parameters look great, we say, great, we'll do an IUI tomorrow, because it should happen 36 hours after the surge. okay? And so LH peak doesn't reach its detection. We don't really need to talk to that. But it's useful for timing IUI because we do the IUI 36 hours after we do the trigger shot. What about metformin? So we've talked a lot about PCOS today, and a lot of women that are with PCOS are on metformin. So metformin is a bigonide. It's an insulin sensitizer. It decreases hepatic gluconeogenesis. It increases intestinal absorption of glucose, and then it increases peripheral glucose uptake and utilization. So it does increase ovulation rates in some women, and especially women that show insulin resistance. And you can find insulin resistance by doing like a fasting insulin. The book Text Answer is a 2-hour glucose tolerance test. Check their A1C, make sure they're not pre-diabetic. And so the people that really benefit most from metformin are the people that are anovulatory, and then they're also demonstrate some signs of insulin resistance. Obesity is a sign of insulin resistance. So, I mean, women that are obese with PCOS benefit from metformin. So how does it work just as well as Clomid? And the answer is no. The answer is that it works best in conjunction with ovulation induction agents. So you're not going to get the best success rate by just saying to someone with PCOS, oh, here, take some metformin and come back and see me in 3 months. We'll see how you're doing. You should be pregnant by then. No, like it needs to be used in adjunct with either Clomid or letrozole. And if you use the live birth rates in this group, this was a really, really great success rate. For oral medication, that is not normal. So when I looked at this trial, I was like, wow, they must have really fertile people, because generally I still say around 15%. The problem with Clomid is that it has a lot of problem with metformin is that it has a lot of side effects. So what you do when you start people on this medication, the reason why it has side effects is because of the reason why it's working. So it moves all glucose into your gut and pushes it out. So what do people complain of? Nausea, vomiting, diarrhea, okay? And so I usually use the extended release version, always the extended release version because side effects are less. I start at 500 milligrams, and I just stepwise go up every week based on their symptoms. So I say, hey, start at 500 milligrams. I want you to take it one a day for a week. Then the next week, I want you to take 2 a day for a week. I want you to sort of assess, see how your symptoms are. If they're too much, then you just say, okay, I'm going to stay at 2 or I'm going to go back to 1. But the ideal is that they're on 1,500 milligrams of metformin. All right, so now we're going to talk about sort of my favorite oral medication, and it is sort of replacing Clomid. Clomid is the old standby. All of the studies are done on it, but letrozole sort of emerged when the year before I was a fellow as this option for women. So letrozole, or Femara, is an aromatase inhibitor, and it blocks peripheral conversion of estrogen. So it works in a similar way to Clomid, in that, again, estrogen levels are low. Your brain responds by talking to your ovaries saying, hey, estrogen levels are low, we need to make an egg, okay? But it works kind of a little bit faster than Clomid, and 10 studies have shown that it's trending to be more successful. The other benefit of letrozole is that it is not an estrogen antagonist at the uterine lining, so you don't have those lining effects that you do with Clomid. You don't have the cervical mucus thickening, anything like that. So, most commonly, I treat it the same way that I treat Clomid. So I do 5 milligrams on days 3 through 7. The pharmaceutical starting dose is 2.5. I will say nobody ever ovulates with 2.5. And you're not gonna blow somebody out of the water by just starting them on 5. So I never use 2.5. I go straight to the 5, and if they don't ovulate with 5 milligrams, I go up to 7.5. But Again, it's the same idea as Clomid. You take it on cycle day 3 through 7. They come in for an ultrasound on days like 12 through 14. We take a look. We see if they make an egg. And the optimal dose probably ranges between 5 milligrams and 7.5 milligrams. The available data suggests that aromatase inhibitors should be used as first-line treatment for ovulation induction in women with a diagnosis of PCOS. Some studies, and where it's sort of kind of, we're not there yet, are showing that it's kind of surpassing Clomid with unexplained infertility. So, all right, so what we do, the garden variety, the biggest thing that we do, other than IVF, is we use injectable medication to make people ovulate many eggs, okay? And these are called exogenous gonadotropins, okay? They've been around forever. They were originally the one that we use we get it from overseas because it's not even available in the United States, is HMG, or human menopausal gonadotropin. It's basically urine of postmenopausal women has a lot of like FSH and LH in it, and so they kind of purified it and put it in a little vial. And you do it IM, so it's intramuscular injection. And people stopped using HMG because the drug companies developed this fantastic drug called Menopur, and Menopur can be administered subcutaneously and is much more highly purified. But more commonly, what we use are derivatives of FSH. So what they did was it's fascinating, and I'm not going to think it's beyond my level of knowledge, but they genetically engineered hamsters, and using their ovaries, they were able to kind of create FSH derivatives. So they're genetically engineered drugs, and it has a little bit shorter half-life than like the natural FSH, but what they've created as a genetically engineered drug is folitropin alpha, which is gonal F, and folitropin beta, which is follistim. So that is basically hormonal FSH, okay? There's subtle differences in like how they look, but they sort of taste the same. We always say in our office it's like Coke or Pepsi. Like they work the same way. It's just they're just a little subtle changes and these are significantly cheaper than other medications, like Menopur. So I love Menopur. Menopur is my favorite drug. Everyone in my office knows it. And the reason why is that it contains both FSH and LH, and both of those hormones are required in order to correctly develop and mature and release an egg. But the problem with Menopur is it's super expensive. So it's like, I don't know, like $80 a vial or something, and if you're giving a lot of vials, it's that's when you can really, really increase the cost per patient. So a lot of times I use just follistim or gonal F unless there's somebody whose brain is not talking to the ovary appropriately. So those World Health Organization class 1 anovulatory women. So women where it's a function where their brain isn't connecting appropriately because they need both LH and FSH because they have neither. Okay. Anytime that you use injectable medications, you're altering kind of what we call the luteal phase, which is like the second half of the menstrual cycle. So what you're doing is you can like shorten it or lengthen it, and it all depends on the patient. But the bottom line is there's a recommendation whenever you're using any kind of gonadotropins that you supplement the second half of the cycle with progesterone. So some people in another clinic across town, they do HCG like every other day, and that's part of the Pope Paul method. That's what they do. That's why they do luteal phase support. But we do progesterone because it's the same. It works the same way. But the bottom line is you just want to give that progesterone because you may have altered the normal luteal function by giving these medications. So people with PCOS tend to have normal FSH levels and high LH levels. In these women, I generally only use FSH alone for cost and also clinically because they don't really need the LH. They already have endogenous LH. And it works. The problem when you stimulate people with PCOS is that there is a really, really narrow therapeutic range, okay? The bottom line is it's the Goldilocks phenomenon. It's either too little or too much. And you can't tell by looking at them. There's no way. So you start off on the lowest dose. They come back. They're not making any eggs on ultrasound. And you're like, why isn't this working? Why is their estrogen just baseline? And you rank up on their dose a little bit, and you have them come back in 2 days, and now they've got 20 follicles. And you're like, well, I don't want you to be the next Octomom. So this is we're not doing this cycle. So certainly these women with PCOS, when we use injectable medications, we have very, very long talks with women about increased risk of multiples. We talk about multifetal reduction if that's a possibility. We sort of set a goal with the patients on like, what is your comfort level on how many of eggs? Because mine is like 4 to 6, and that's like done. It's unexplained infertility. Any kind of superovulation is always best when you use it with IUI. When you use gonadotropins alone, or when you use oral medications like Clomid or letrozole alone, the bottom line is that they don't work. They work half as much as they do with IUI. So if we say that our success rate is 15%, if they don't do an IUI, it's less than 10%. So it really benefits patients with unexplained infertility to do IUI. There's talking a little bit about safety. We talked a little bit about in the PCOS population, but we also have to talk about in like the weight population. So we do not have a BMI cutoff at our clinic, and like I said, but I have a very hard time unless I can get someone with a BMI less than 45 to feel comfortable giving them injectable medications safely, because you can't see their ovaries on ultrasound. And so you don't know how many you're trying. You don't know how many are there. So you're sort of saying, I see 3, but there could be 20. And again, that is never good to get a patient who's morbidly obese with chronic medical conditions pregnant with quads. That's not what our goal is. And so I always tell patients that, like let's get it to a point where I can safely stimulate your ovaries, and we're going to go. And if that is not an option, meaning we don't have time, then I say what we need to do is we need to do fertility preservation, where I stimulate you, we do IVF, we freeze embryos, you lose the weight, and then we can transfer the embryos back to you when you're at a kind of safer or more stable weight, just because it benefits you and it benefits your baby. So usually, like I say, the way that the gonadotropins work and how you can kind of prep your patients if they're going to come to see us is we start them on the lowest dose, generally around 75. They take that for 5 days. They come in for an ultrasound and an estrogen level. And what we're looking for is how many are developing and how high is the estrogen level. Usually we trigger when that lead follicle gets around 18 to 20. What I'm looking for is I want 3 to 4 follicles. Like that is my go-to, which sounds crazy, but that's what I want to get people pregnant. And in our clinic with these gonadotropin plus IUI levels, our success rate is 25%. So it's a difference of 10% with the oral medications. You have to do it very carefully with PCOS patients. Oftentimes you have to start with lower doses. I always tell patients that her PCOS, and it's usually a gestalt on kind of the appearance of their ovaries, because if their antral follicle count, meaning the number of eggs that they have, is like 60 to 80, then there is a high possibility that you're going to be canceled. And so we talk about that before stimulation is started. You can do, the other options that you can do is you can do Clomid plus some injections. So you can do, or letrozole plus some injections, and it's sort of like a hybrid, kind of we called it mini stim. The problem with it, and the reason I don't really like it, is that it doesn't have any higher success rate than the oral, which is 15%. So I'd rather just go for broke. So monitoring is really important. We want to make sure that they're working appropriately. We want to avoid ovarian hyperstimulation syndrome. We want to avoid the risk of multiple pregnancy. Generally, I quote 25% chance of twins if we're using injectable meds in IUI, and about a 1 to 3% chance of higher order multiples, okay? And we monitor estrogen levels because we want to make sure that we're not blasting them out of the water. When you typically, E2 levels rise at an exponential rate. And so what you want is doubling over every 2 to 3 days. And if the slope is kind of shallower, you may need to go up on the medication. But again, we're sort of monitoring this really, really closely. And we always tell patients that in a natural cycle, if we weren't using medication at all, a really good, robust ovulation is when you make an egg, it's 18 to 20 millimeters on ultrasound, and your estrogen level is right around 200, okay? Because that's natural. So again, if you're stimulating somebody and the estrogen level with a peak follicle is only 150, success rate drops. And part of that is egg quality. That is just a definition of egg quality. Cycle fecundity increases with E2 levels. The best levels, kind of what we're looking for, is 500 to 1,500. And we usually don't get pregnancies when they're less than 200. In a normal cycle, the dominant follicle usually has shown itself by day 8 through 12, and they grow around 2 millimeters a day. So I always tell patients if they've taken their medicine for 5 days, they come in on day 6, mostly for that estrogen check. I usually have them come back on day 9 or 10, okay? And I'm able to count based on my ultrasound, okay, you had a 13 on day 9. By day 11, that should be a 15. And by day, 13, that should be a 17 or 18. And so that's how you can sort of gauge, and that's why we don't need people coming in every single day for ultrasounds, because we're sort of assessing how those follicles are growing. It usually measures 20 to 24 when you're LH surge, and lesser follicles rarely exceed 14 millimeters. So let's say that you've got somebody that comes in, and you've given them gonadotropins, and they've got 15 follicles. And if you're me, you're sweating because you're oh my gosh, I'm gonna have to cancel this patient. Oh wait, they're all 14, and there's only one 18. Then you're okay, because the bottom line is there was really only one follicle that really developed in that cycle. So I usually say if they're not comfortable with reduction, if they cannot consider a multifetal reduction at the end of the day. If they'd rather not be pregnant, then we cancel the cycle if there's greater than 6 follicles that are 18 or over. That is sort of my we're not going through. We've talked a little bit about ultrasound, but we always do a baseline ultrasound because we don't want to stimulate in the presence of cysts. And we usually put people on suppressive therapy, meaning oral contraceptive pills, if they do develop a cyst, because usually then that cyst is gone the next month. And then the big thing that you also want to look for is endometrial thickness, and you want it greater than 7 millimeters. So 20, usually these are the data for national groups, but ours is 25% all around. I would say probably our PCOS patients are probably closer to 30%. The unexplained are 25%. So it's they work. They're not IVF, which is 65%, but they work. 25% of gonadotropin pregnancies have twins. And it is monozygotic twinning, so where the embryo splits. The normal frequency is 0.3 to 0.4%. Unfortunately, with gonadotropins, it's higher. It's also higher with IVF. With IVF, it's about 3%. We do see a higher rate of spontaneous miscarriage in these cycles, particularly if we do not supplement with progesterone. Again, the idea is that you're altering that luteal phase. The progesterone can drop. And so if you're ever going to use these medications, which normally they're sent to us, if you're going to use these medications, you got to supplement with progesterone, or you're really altering kind of the normal function. No evidence that it's associated with abnormalities. Let's talk briefly about OHSS. Some of you guys are floor nurses, and sometimes we get hyperstimulation syndrome in these patients. So OHSS happens when your ovaries are normally the size of walnuts, and we're making them the size of like big grapefruits, okay? And for like an IUI cycle, again, my goal is like 3 to 4 follicles, okay? But there's also going to be like small follicles that are like 14 or 15. My goal for IVF is like 15 follicles. So you can imagine that you go from not feeling your ovaries, like I don't feel those on a daily basis, but you can imagine that if they get that big, you're going to feel full, okay? But what also happens is when you give someone HCG, that sort of triggers the ovaries to release hormones. They release cytokines. They release all of these things that basically make it so that your vessels become leaky and you have increased vascular permeability. So you start to third space. So the blood that was in your blood vessels is now kind of in your abdomen or in your chest, or it's like in your skin. Like sometimes these women get like edema just from kind of so much fluid excess. And so they get really dry. And so part of when we admit them is rehydration, but we want to make sure that we're not overhydrating them. And we want to make sure that we're keeping those kidneys perfused. We don't know the exact mechanism, but we think it has something to do with VEGF. What are some risk factors? So young age, low body weight, PCOS, higher doses of gonadotropin. The big one is if you've had OHSS before, you might have it again. High serum estrogen levels, large number of developing ovarian follicles. And what I mean by that is like you may have somebody like the patient I was talking about, like that there was 20 follicles, but there was 118 and a ton of 14s. All those 14s are going to secrete that hormone as soon as you give HCG. And so it's really those kind of smaller follicles and the number of small follicles that they have. So it really depends on the count. And if you use HCG for luteal support, like I was talking about, as an option, unfortunately, that also increases your risk for hyperstimulation. That's why we just use progesterone. So how do these women feel? Okay, so I already said they feel like bloated. They're like, oh, this is terrible. They might have some like mild nausea and vomiting, and this is mild OHSS. They get diarrhea. They're going to be distended. And again, they may have fluid in their abdomen, so they may have ascites. And it occurs, like mild OHSS, where they just like feel kind of crummy, occurs in about 1/3 of cycles, okay? You can treat them with oral pain medicines, and you counsel them. We send everyone home with a hat for their urine. They need to make it at least 30 cc's an hour. They call if you're not able to keep any food down or any water down. Avoid intercourse, avoid exercise. Just really take it easy. So you can use like Zofran. Where I trained before, we had everybody come in and they would get daily weights and like we would tally their urine for us. That's a little excessive. I don't think people want to come into our clinic every single day. But if someone's like really calling and they're not eating, they're vomiting, the first thing that we're going to do is assess them for ascites, meaning fluid in their abdomen, and then we're going to look at their blood counts, we're going to look at their electrolytes, and especially like their creatinine to make sure their kidneys are appropriate. Like I said, you want to make sure that they're drinking, that they're not drinking that much. But we usually say, like, you have to drink at least 1 liter. Like, that's the minimum. And so best things for them to be drinking, though, are, like, electrolyte supplements. So, like, Pedialyte, Gatorade, all that kind of stuff. Avoid strenuous activity, but what happens when when your blood gets really thick, because you're third spacing, you develop blood clots. So we want you taking it easy, but we don't want you laying down all the time. Like, at least get up and walk around the room. And weight gain, if they gain greater than 2 pounds daily and their urinary frequency is decreasing, like, they need to come in and they're probably going to need to be admitted. If they're pregnant, which rarely happens, like this is less than 1% of the time, that as their HCG rises in pregnancy, that beta HCG rises, that fuels fans the flames of OHSS. So you can imagine that if you get them pregnant and they have OHSS, then they're going to get really sick. So severe OHSS. So 1% incidence, and I would guess that this is probably lower now given the advent of loop-run triggers, but that is for IVF, the next talk. They have severe pain. They call you, they can't get off the couch. Actually, they're not calling you, their husband is calling you, or their partner is calling you and saying, like, she can't move. Their abdomen is like tense ascites. Like, they look like they're 9 months pregnant. A lot of times they can't breathe. Now, sometimes you can't breathe if you're distended. There's a difference between that kind of breathing or there's fluid in my lungs and I can't breathe. And that's why they have to kind of come and be evaluated if they call with that. Progressive low urine output, and then laboratory abnormalities. Their hematocrit is high. Their K is low, their creatinine is through the roof, their sodium is low, and then like they can become short of breath from either the ascites or hydrothorax. So people that require admission are people that are hemoconcentrated, people that can't tolerate fluid intake, people that have renal, it has really affected their kidney. And that's really about it. Most people can be managed as an outpatient basis, but those are kind of the things when you sort of meet that definition of, you're showing laboratory abnormalities in addition to not being able to tolerate like any kind of fluid at home, then you need to be admitted. And the problem is that this is a self-limited illness as long as they're not pregnant. But it generally takes, it's about 10 days from when you took the HCG trigger for you to feel better. So they can be in the hospital for like 7 to 10 days getting kind of just supportive care. And that is the end, you guys.